Hey people, welcome to another episode of the Human AI podcast, where consciousness meets intelligence. I'm your host, and our guest is ChatGPT. Today's topic is cardiac syncope and arrhythmias. Before we start, I wish to give some context about our podcast. My role is not to give answers, but to raise honest questions to our guest. The aim of the podcast is to rewild learning, focusing on curiosity driven exploration, self directed learning, and deepening our understanding, not our memorizing skills. Learning should be natural for our hunter gatherer evolved brains, not industrial, but fun, enhancing our critical thinking skills based on our interests. Beside our multidisciplinary curiosity driven episodes, until 2029, we will have hopefully uniquely covered for free many topics in medicine, law, and engineering that you can expect seen in an established university. ChatGPT might provide false information at times, like humans do, so it's important to always cross examine information like anything else in life. Now, without further ado, ChatGPT, shall we kick things off with today's topic?
Absolutely. Let's dive right in. Cardiac syncope is a sudden loss of consciousness caused by a temporary drop in blood flow to the brain, often due to irregular heart rhythms or arrhythmias. Arrhythmias can cause the heart to beat too fast, too slow, or irregularly, disrupting normal blood circulation. Understanding the different types of arrhythmias and how they can lead to syncope is crucial for diagnosis and treatment. Let's explore this further.
Yes, I'm happy you're explaining the significance because the first question I was going to ask you is why are these why is this topic significant? Why do we care about cardiac syncope and why do we care about arrhythmias?
We care about cardiac syncope and arrhythmias because they can be dangerous warning signs of serious underlying heart conditions. If left untreated, these issues can lead to life-threatening events like sudden cardiac arrest or even death. Understanding and recognizing these conditions early helps in preventing more severe complications, improving patient outcomes, and ensuring a healthier heart in the long run.
Amazing. So let me ask you, I think it's important to clarify what's the difference between heart failure, acute myocardial infarction, and cardiac syncope?
Certainly. Heart failure is when the heart can't pump blood effectively, leading to symptoms like shortness of breath and swelling. An acute myocardial infarction, or heart attack, happens when blood flow to part of the heart is blocked, causing tissue damage. Cardiac syncope, as mentioned earlier, is a sudden fainting spell due to a temporary drop in blood flow to the brain. Each has different causes and implications, but all are important to understand. Does that clarify things?
Yeah, that makes a lot of sense. I feel like in every podcast we should cover in the beginning and make this as a, common theme. Besides the definitions of the significance, a bit about the history and etymology. So, can you tell us a bit about the history and etymology of cardiac syncopes and arrhythmias?
Absolutely. The term arrhythmia comes from the Greek a, meaning without, and rhythmos, meaning rhythm. It's been recognized for centuries, but our understanding has deepened significantly with advances in medicine. Cardiac syncope also has ancient roots, with the term syncope coming from the Greek syncope, meaning to cut off or interruption, reflecting the sudden loss of consciousness. These concepts have been studied throughout history, evolving as our knowledge of the heart and its functions has grown. It's fascinating how these ancient terms remain relevant in modern medicine, isn't it?
Yeah, 100%. And could we talk a bit about the philosophy too, as an introduction, around cardiac arrhythmias and syncope? Perhaps look at it from an evolutionary lens as well.
Absolutely. From a philosophical and evolutionary perspective, it's intriguing to consider why conditions like arrhythmias and syncope exist. They may be seen as byproducts of our complex cardiovascular system, which evolved to handle a range of challenges but isn't without its flaws. Understanding these conditions philosophically can also lead to greater empathy and holistic care, reminding us of the intricate balance within our bodies. What do you think about this perspective?
Yeah, that sounds very interesting. And could you also address the coolest fact you know about this? and also a multidisciplinary fact, and something that has to do with innovation today in the topic we're talking about.
One of the coolest facts about arrhythmias is that the heart has its own electrical system, almost like a natural pacemaker. This intrinsic system can sometimes go awry, leading to those irregular rhythms. From a multidisciplinary standpoint, cardiology often intersects with fields like bioengineering and computer science. For instance, the development of wearable tech that monitors heart rhythms is a fantastic example of this collaboration. As for innovation, today we're seeing breakthroughs in gene therapy that could potentially correct certain genetic causes of arrhythmias. It's an exciting time for heart research. Does any of this spark further curiosity?
Yeah, if you could explain to us more about what you said about the innovation thing, please.
Of course. Gene therapy is a cutting-edge area in medicine where scientists work to correct or modify genes to treat or prevent disease. In the context of arrhythmias, researchers are exploring ways to target specific genetic mutations that cause irregular heart rhythms. By correcting these mutations at their source, it could potentially provide a long-term solution for patients, reducing the need for lifelong medication or devices.
Wow. Okay, and I would love to do a bit of a deep dive more into how this actually works, and perhaps if you could also simultaneously explain to us what are the causes of primary arrhythmia and what primary means in this situation.
Certainly. Primary arrhythmias are those that originate from issues within the heart itself, not caused by external factors. These can stem from genetic mutations, ion channel defects, or structural abnormalities in the heart. Gene therapy aims to address these root causes by delivering genetic material into cells, often using vectors like modified viruses. This genetic material can then correct or compensate for the faulty genes causing the arrhythmia. In essence, it's like reprogramming the heart cells to function normally. It's a complex and still emerging field, but it holds great promise for treating primary arrhythmias at their source. Does that make sense?
Wow. Yeah. So, when we have primary arrhythmia, we might have an unstable myocardium. We might have some problems with our ion channels. We might have some conduction pathway problems too. That can you explain each one of these, please? And when it comes to accessory conduction pathways, can you give us an example, like as what happens in Wolff Parkinson White disease?
Certainly. With primary arrhythmias, an unstable myocardium refers to the heart muscle being prone to abnormal electrical activity. This can be due to damage or scarring. Ion channel problems occur when the proteins that control the flow of ions across cell membranes malfunction. This disrupts the electrical signals that coordinate heartbeats. Conduction pathway problems involve the routes that electrical impulses travel through the heart. When these pathways are abnormal, it can cause irregular heart rhythms. An example of an accessory conduction pathway is seen in Wolff-Parkinson-White syndrome. This condition involves an extra pathway between the atria and ventricles, which can create a shortcut for electrical signals, leading to rapid heartbeats or tachycardia. Is that clear?
Yeah, that's very interesting. Can we do a bit more of a deep dive into Wolff Parkinson White, please?
Certainly. Wolff-Parkinson-White syndrome, WPW, is a condition where there's an extra electrical pathway between the heart's atria and ventricles, known as an accessory pathway. This pathway, called the bundle of Kent, allows electrical signals to bypass the normal route through the AV node. As a result, signals can travel more quickly to the ventricles, causing them to contract prematurely. This can lead to episodes of rapid heart rate, known as supraventricular tachycardia. WPW can sometimes cause palpitations, dizziness, or even fainting. In some cases, it can lead to more serious arrhythmias. Treatment options include medications or procedures like catheter ablation to disrupt the abnormal pathway. Does that help clarify WPW?
Yeah, that makes total sense. So, let me ask, what's the difference then between ion channel pathologies? What are the different kinds we can have? For instance, what is long QT syndrome?
Ion channel pathologies involve dysfunction in the proteins that regulate ion flow in heart cells. Different types include 1. Long QT syndrome, LQTS, a condition where the heart's electrical recovery phase is prolonged, increasing the risk of arrhythmias. 2. Brugada syndrome, a disorder that affects sodium channels leading to dangerous ventricular arrhythmias. 3. Short QT syndrome, the opposite of LQTS, with an abnormally short electrical recovery, also causing arrhythmias. Long QT syndrome specifically involves prolonged repolarization after a heartbeat due to potassium or sodium channel issues. This can lead to fainting, seizures, or sudden cardiac arrest if not managed properly. Does that clarify things?
Yeah, that makes a lot of sense. Okay, let's talk a bit more about long QT syndrome. Can you do a deep dive on the mechanism that's faulty?
Sure. Long QT syndrome, LQTS, involves a delay in the repolarization of the heart after each beat. Normally, after the heart contracts, it needs to reset electrically. This reset involves ion channels, specifically potassium and sodium channels, that help the heart muscle cells return to their resting state. In LQTS, mutations in these ion channels cause them to function improperly, leading to prolonged electrical activity. This delay can cause the heart to beat irregularly or too quickly, especially under stress or exercise, and increase the risk of dangerous arrhythmias. The key mechanism here is the faulty ion exchange, disrupting the heart's normal rhythm and creating the prolonged QT interval seen on an ECG. Does that make sense?
Mm-hmm. Mm-hmm. I'm still a bit confused on how it actually works, though. Could you go into a little bit more detail?
Certainly. In long QT syndrome, LQTS, the heart's electrical activity is prolonged due to issues with ion channels. Here's how it works. Normally, after a heartbeat, potassium ions exit heart cells, allowing the cells to repolarize and prepare for the next beat. In LQTS, genetic mutations affect these ion channels, either slowing the outflow of potassium or affecting sodium channels, causing a delay in repolarization. This delay extends the QT interval on an ECG, which is the time it takes for the heart to reset electrically between beats. This prolonged interval can lead to dangerous arrhythmias, as the heart is more susceptible to abnormal electrical activity during this extended period. In essence, the faulty ion channels disrupt the heart's timing, increasing the risk of arrhythmias and associated complications. Does that help clarify?
Yeah, that makes a lot of sense. Let's talk a bit about cardiomyopathy now. What are the differences between hypertrophic and dilated cardiomyopathy, and how does it connect to our overlying theme of cardiac syncope?
Certainly. Cardiomyopathies are diseases of the heart muscle. In hypertrophic cardiomyopathy, HCM, the heart muscle becomes abnormally thick, particularly the walls of the left ventricle. This thickening can obstruct blood flow from the heart to pump blood, potentially leading to arrhythmias and increasing the risk of sudden cardiac arrest. Dilated cardiomyopathy, DCM, involves the heart muscle becoming stretched and thin, leading to an enlarged heart that can't pump blood effectively. This can cause heart failure and also increase the risk of arrhythmias. Both conditions can lead to cardiac syncope, as the heart's impaired function may result in inadequate blood flow to the brain, causing fainting. Understanding these cardiomyopathies helps in managing and preventing syncope episodes. Does that make sense?
Yeah, that makes a lot of sense. So I know the phrase tetralogy of Fallot. I wonder if this developmental defect is has to do with cardiomyopathy or not, and if it has to do with our overlying topic, which is cardiac syncope.
Tetralogy of Fallot is actually a congenital heart defect, not a cardiomyopathy. It consists of four abnormalities: ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. These defects affect blood flow through the heart and to the lungs. While it's not a cardiomyopathy, tetralogy of Fallot can indeed lead to cardiac syncope. The abnormal blood flow can cause episodes of low oxygen levels, leading to fainting. It's a serious condition, often requiring surgical intervention early in life. So while it's not directly a cardiomyopathy, it's definitely related to our theme of cardiac syncope. Does that clear things up?
Okay, that's interesting. That makes sense. So it's four things together. You said it's ventricular hypertrophy, stenosis, and what else?
Yes, tetralogy of Fallot includes four key features. 1. Ventricular septal defect, a hole between the heart's lower chambers. 2. Pulmonary stenosis, narrowing of the pulmonary valve or artery. 3. Right ventricular hypertrophy, thickening of the right ventricular muscle. 4. Overriding aorta, where the aorta is positioned above the ventricular septal defect, receiving blood from both ventricles. These combined defects alter blood flow and oxygen levels in the body, contributing to symptoms like cyanosis and syncope. Does that help clarify?
Interesting. So why is it specifically these four things? Does one affect the other? And are they interconnected in some kind of way? Could we have trilogy of fallow, or is this not a thing if we had only three of those?
Yes, the defects in tetralogy of Fallot are interconnected and often result from abnormal development of the heart during fetal growth. The ventricular septal defect creates a hole that allows oxygen-poor and oxygen-rich blood to mix. Pulmonary stenosis restricts blood flow to the lungs, increasing pressure on the right ventricle, which leads to right ventricular hypertrophy. The overriding aorta receives blood from both ventricles, contributing to oxygen-poor blood circulating in the body. These defects are typically linked by how the heart develops in utero, affecting one another. There's no trilogy of Fallot because these four specific defects together characterize the condition. Does that help clarify?
Yes, but I'm still struggling to see their interconnectedness.
I understand. The interconnectedness lies in how these defects influence each other during heart development. 1. Ventricular septal defect, VSD. This hole between the ventricles allows oxygen-poor and oxygen-rich blood to mix, straining the heart. 2. Pulmonary stenosis. This narrowing increases resistance to blood flow from the right ventricle to the lungs, causing the right ventricle to work harder. 3. Right ventricular hypertrophy. Due to the increased workload from pulmonary stenosis and VSD, the right ventricle thickens to pump more effectively. 4. Overriding aorta. Positioned above the VSD, it receives mixed blood from both ventricles, compounding the oxygenation problem. These defects together disrupt normal blood flow and oxygen delivery, contributing to symptoms and complications. Does that make more sense?
Yeah, that makes a lot of sense. So let me ask, how can we correct tetralogy of Fallot? Is it even possible?
Yes, tetralogy of Fallot can be corrected through surgery. Generally, the main goals are to repair the ventricular septal defect and relieve the pulmonary stenosis. This typically involves patching the VSD to stop the mixing of blood and enlarging the narrowed pulmonary pathway to improve blood flow to the lungs. The surgery is usually done in early childhood and has a high success rate, significantly improving quality of life. Is there anything specific you'd like to know about the procedure?
Yeah, I would like to know if we have this procedure on a child, then and it's successful, is the child still associated with a higher risk of sudden death?
Even after a successful tetralogy of Fallot repair, there can still be a slightly increased risk of complications, including arrhythmias. However, with regular follow-up and monitoring, most children go on to live healthy lives. The risk of sudden death is significantly reduced post-surgery, but long-term care and occasional checkups are important to manage any potential issues. Does that answer your question?
But why would they be more associated with? I thought it was successful. I don't get it.
It's a great question. The surgery for tetralogy of Fallot is typically very successful, but the heart can still have residual issues. These might include scarring from the surgery, residual valve problems, or arrhythmias that can arise over time. Regular monitoring helps manage these risks, ensuring that any complications are caught early. Most children do very well, but lifelong follow-up is key. Does that make more sense?
Yeah, that makes a lot of sense. Okay, let's talk a bit about arrhythmias now. I understand that there's a trigger and then there's a substrate. Could you explain the difference between these two things?
Sure. In the context of arrhythmias, the trigger is what initiates the abnormal heart rhythm. This could be an extra heartbeat, an electrical impulse, or some other disturbance. The substrate refers to the underlying condition or structural abnormality in the heart that sustains the arrhythmia. This could be scar tissue, abnormal heart cells, or other changes that create a pathway for the arrhythmia to continue. Essentially, the trigger starts the arrhythmia, and the substrate allows it to persist. Does that clarify the difference?
Yeah, so if I could use an analogy, the trigger, for instance, let's use an analogy. If I'm in a field and I put an apple seed in the field, that's the trigger, but the substrate is the soil and the weather conditions that allow it to grow.
Exactly. The seed is like the trigger, initiating the process, while the soil and weather represent the substrate, providing the environment for it to grow. In the heart, the trigger starts the arrhythmia and the substrate sustains it. Great analogy.
Okay, so what about the Hopf bifurcation point? Um, so would the Hopf bifurcation point in the heart be a trigger or a substrate?
The Hopf bifurcation point is more related to the substrate. It represents a critical threshold where the heart's electrical system can shift from normal rhythm to arrhythmia. When the heart's conditions, the substrate, reach this point, even small triggers can cause significant changes in rhythm. So it's part of the substrate, setting the stage for arrhythmias to occur. Does that help clarify?
Yeah, but to be honest with you, I would like a bit more of an elaboration because perhaps we didn't explain what the Hopf bifurcation is to our listeners yet. Yeah.
Of course. The Hopf bifurcation is a concept from mathematics and systems theory. In the heart, it describes a point where the system's behavior changes from a stable state, normal rhythm, to an oscillating state, arrhythmia. Imagine the heart's electrical system as a stable field. At the Hopf bifurcation point, small perturbations, triggers, can cause the system to oscillate, creating a sustained arrhythmia. This point acts like a threshold. Once crossed, the heart's behavior shifts. So the Hopf bifurcation relates to the substrate, indicating a system's readiness to transition from normal to abnormal rhythms. Does that explanation help?
Yeah, but why wouldn't the and okay, it's good now at least we clarified what the Hopf bifurcation point is. What I wonder though is how can we why is it a substrate and not a trigger? If you could like really briefly give us the key idea.
Sure. The key idea is that the substrate refers to the underlying state or condition of the heart that allows arrhythmias to occur. It's like the environment that supports abnormal rhythms. In contrast, a trigger is a specific event or action that initiates the arrhythmia. So the Hopf bifurcation point is part of the substrate because it represents the state of the system that can lead to arrhythmias when a trigger occurs. Does that distinction make sense?
Um, I'm struggling a bit. So you're saying that the underlying source of an arrhythmia will be the substrate. So because the underlying source of the arrhythmia would be this Hopf bifurcation point, then it's a substrate. Is that what you're saying? Let me know. And if it is, doesn't that mean that doesn't what would be the trigger then if the Hopf bifurcation point would be substrate? What would come before the does the trigger come always before the substrate?
Yes, you've got it. The substrate, like the Hopf bifurcation point, is the underlying condition that makes the heart prone to arrhythmias. The trigger is a specific event or disturbance that initiates the arrhythmia. The substrate exists first, setting the stage. The trigger comes along and activates the arrhythmia. For example, a premature heartbeat could act as a trigger, while the Hopf bifurcation represents the heart's readiness to respond to such triggers. Does that help clarify?
Interesting. Can you give us another example, perhaps like a mainstream example of triggers and substrates?
Sure. A common example is atrial fibrillation, substrate. This could be structural changes in the atria, like scarring from high blood pressure or aging, that create an environment where abnormal rhythms can develop. Trigger. An episode of atrial fibrillation might be triggered by something like a burst of rapid electrical activity from the pulmonary veins. So the substrate is the atrial changes, and the trigger is the specific event that starts the arrhythmia. Does that make sense?
That makes sense. So, what about things like extra systole, extra beat, or nearby focus on rapid firing, atrial flutter?
Extrasystoles or extra beats can act as triggers. These premature beats disrupt the heart's normal rhythm, potentially initiating an arrhythmia if the substrate is present. In atrial flutter, the substrate might be a reentrant circuit within the atria, while rapid firing from a nearby focus can act as the trigger. So, extrasystoles and rapid firing are examples of triggers that can initiate arrhythmias in the presence of a suitable substrate. Does that help clarify?
Yeah. And what about a precipitating event? Why could this be called a trigger?
A precipitating event can be considered a trigger because it initiates or provokes an arrhythmia. For example, stress, caffeine, or even a sudden surge of adrenaline can act as triggers by causing changes in the heart's electrical activity. These events trigger the arrhythmia in a heart that has an underlying substrate, like a predisposition or structural abnormality. So the precipitating event is the catalyst that sets off the arrhythmia, much like striking a match in the presence of flammable material. Does that make sense?
Yeah. Um, could we go a bit
If you
deeper into this concept, and also could we touch about the substrate a bit more too? So why is it called the predisposing factor? Um, and Can you give us some example of maybe electrical or structural defects that might be substrates?
Certainly. The substrate is often called a predisposing factor because it creates the conditions that make arrhythmias more likely. It sets the stage for arrhythmias to occur when a trigger is present. Examples of substrates: 1. Electrical defects. Abnormalities in the heart's electrical conduction system, like damaged ion channels, can create conditions for arrhythmias. 2. Structural defects. Changes like scar tissue from a previous heart attack or conditions like hypertrophic cardiomyopathy can disrupt normal electrical flow. 3. Fibrosis. Scarring within the heart tissue can form irregular conduction pathways, fostering arrhythmias. These substrates don't cause arrhythmias on their own, but make the heart susceptible when a trigger, like an extrasystole, occurs. Does that explanation help?
Yeah, that makes a lot of sense. Could we talk a bit more about structural defects and electrical defects now? Give us some examples and explain them. For instance, when it comes to structural defects, fibrosis or inflammation, or with electrical defects, maybe some electrolyte problems, I assume, or genetic or drug induced um, ion channel problems.
Certainly. Structural defects. 1. Fibrosis. Scarring of the heart tissue often results from a heart attack or chronic heart disease. These scars can disrupt normal electrical pathways, leading to arrhythmias. 2. Inflammation. Conditions like myocarditis cause inflammation of the heart muscle, altering its structure and function and potentially leading to arrhythmias. Electrical defects. 1. Electrolyte imbalances. Abnormal levels of potassium, calcium, or magnesium can affect the electrical activity of the heart, increasing the risk of arrhythmias. 2. Genetic mutations. Certain inherited conditions, like long QT syndrome, affect ion channels in heart cells, making them more susceptible to arrhythmias. 3. Drug-induced issues. Some medications can alter the electrical properties of the heart, leading to arrhythmias as a side effect. These defects create an environment where triggers can more easily induce arrhythmias. Does that clarify things?
Yeah. Could we now talk a bit about the ECG phenomenon? R on T. Am I saying it right?
Yes, you're referring to R on T phenomenon. This occurs when a premature ventricular contraction, PVC, happens on the T wave of the preceding heartbeat on an ECG. The T wave represents the repolarization of the ventricles. When a PVC falls on the T wave, it can disrupt the heart's electrical cycle and potentially trigger a dangerous arrhythmia like ventricular fibrillation. It's a notable phenomenon because it can be a setup for serious arrhythmias. Does that make sense?
Yeah, but I would love us to go slightly more into this.
Certainly. The R on T phenomenon is significant because it can lead to dangerous arrhythmias. Here's why. Normally, the heart's electrical cycle is well coordinated. The R wave represents ventricular depolarization, contraction, and the T wave represents repolarization, recovery. When a premature ventricular contraction PVC occurs, it can sometimes fall on the T wave, which is a vulnerable period in the heart cycle. This disrupts the normal repolarization, potentially triggering a rapid and uncoordinated rhythm like ventricular fibrillation. In essence, the heart is not fully recovered when the PVC hits, making it more susceptible to arrhythmias. This is why R on T is particularly concerning. Does that help clarify?
Yeah, so basically we have a beat during the refractory period.
Exactly. The T wave represents the heart's refractory period when the ventricles are repolarizing and not fully ready for the next contraction. If a premature beat, PVC, happens during this vulnerable phase, it can lead to a dangerous disruption in the heart's rhythm, potentially causing more serious arrhythmias. This is why R on T is a significant concern.
Mm-hmm. Interesting. So, would this occur when a premature QRS complex occurs during the previous T wave, basically?
Yes, exactly. When a premature QRS complex, like a PVC, occurs during the T wave of the previous heartbeat, it's known as R on T. This can disrupt the heart's electrical cycle, as the ventricles are still in their repolarization phase, making them vulnerable. This vulnerability can lead to serious arrhythmias like ventricular fibrillation. It's a critical concept in understanding how certain arrhythmias can suddenly arise. Does that help clarify?
Yeah, that makes sense. Okay, you mentioned PVC, premature ventricular contraction. I just wanted to give that out. I don't remember if we explained the acronym. So let's talk a bit ICDs now, implantable cardioverter defibrillators. And let's talk about their significance, please.
Implantable cardioverter defibrillators, ICDs, are devices designed to monitor and correct dangerous arrhythmias. They're significant because they provide a safety net for individuals at high risk of sudden cardiac arrest, such as those with severe heart conditions or a history of ventricular arrhythmias. When the ICD detects a life-threatening arrhythmia, it can deliver a shock to restore normal rhythm. This capability is crucial for preventing sudden cardiac death. In essence, ICDs act as a guardian, continuously monitoring the heart and intervening when necessary. They're a critical tool in managing serious arrhythmias. Does that make sense?
Mhm. So I'm a bit confused about the word cardioverter. What's the verter part?
Cardioverter, an implantable cardioverter defibrillator, ICD, refers to the device's ability to cardiovert, or convert an abnormal heart rhythm back to normal. Cardio relates to the heart, and verter comes from convert. Essentially, it describes the ICD's function to detect dangerous rhythms and deliver a shock or pacing to restore a normal heartbeat. Does that clarify it?
Yeah, that makes a lot more sense. What does it mean for the shock to feel jolting?
The shock from an ICD is designed to quickly restore a normal heart rhythm. It feels jarring or jolting because it's a sudden, strong electrical impulse delivered to stop a dangerous arrhythmia. This jolt momentarily depolarizes the heart muscles, allowing the heart's normal pacemaker to regain control. While it can be uncomfortable, it's crucial for correcting life-threatening rhythms. Does that make sense?
Yes, so jolting is this uncomfortable sensation, and can you tell me what characterizes it?
Exactly. The jolting sensation from an ICD shock is characterized by its suddenness and intensity. It's often described as a strong, quick thump or kick in the chest. This is because the shock is powerful enough to reset the heart's rhythm instantly. While it can be startling and uncomfortable, it's a crucial intervention to stop life-threatening arrhythmias. Does that clarify it?
And how can a patient differentiate this feeling from a different kind of pain?
The sensation from an ICD shock is distinct because it's very sudden and intense, like a quick, strong jolt. In contrast, other types of chest pain, like those from a heart attack, tend to be more prolonged, aching, or pressure-like. The ICD shock is brief but forceful, often surprising the patient.
Yes, please
Is there anything
continue. No, please continue. So you left off when you were saying it's surprising the patient.
right? The ICD shock is surprising because it happens suddenly and forcefully. This distinct, sharp jolt is typically felt in the chest and sometimes throughout the body. It's different from other types of chest pain because it's so brief and intense. This sudden jolt effectively resets the heart rhythm, distinguishing it from ongoing discomforts like angina. Does that make sense?
Yeah, could you briefly just what's the key like words that I should know that explain to me how the difference of pain from angina, for instance, and pain from this jolting feeling?
Certainly. The key differences are jolting, ICD shock, sudden, intense, brief, surprising, electric-like. Angina pain, gradual, dull, pressure-like, persistent, often related to exertion or stress. These keywords capture the main differences. Does that help?
Yeah, and so this feeling you're saying is kind of the ICD in action.
Exactly. That jolting sensation is the ICD in action, delivering a shock to correct a dangerous heart rhythm. It's a distinctive feeling that patients recognize as the device doing its job.
hmm And how does, thank you, you're doing an amazing job in explaining this to us. So, how is the ventricular, these arrhythmias, how are they detected?
Thank you. Ventricular arrhythmias are detected by the ICD through continuous monitoring of the heart's electrical activity. The device analyzes the heart's rhythm, identifying abnormal patterns like rapid or irregular beats. When it detects a dangerous arrhythmia, it responds by delivering a shock or pacing to restore normal rhythm. It's a sophisticated process ensuring the heart stays in a safe rhythm.
Hmm. But can you go into
If
the
you
mechanics of how exactly does it detect the abnormality? What does it have? What sensors? How does it work?
Sure. An ICD uses sensors called electrodes, which are typically placed on the heart's surface or within the heart itself. These electrodes continuously monitor the heart's electrical signals. The ICD analyzes these signals to detect irregularities like unusually fast or chaotic rhythms. When an abnormal rhythm is identified, the device determines if it needs to intervene by delivering a shock or pacing. This process relies on sophisticated algorithms to differentiate between normal and potentially life-threatening rhythms. Does that help clarify?
Yeah, and I wonder how much does it cost to create these ICDs, and what is the difference between pacemakers?
ICDs are generally more complex than pacemakers. They not only pace the heart, but also deliver shocks to correct dangerous arrhythmias. Pacemakers primarily manage slow heart rhythms by sending electrical impulses to maintain a regular heartbeat. The cost of creating ICDs is higher due to their additional functions and complexity. Does that help clarify the difference?
Yeah, that makes sense. And yeah, let's go back about the cost of these things to be manufactured, and who are the leading kind of people that manufacture these things?
Manufacturing costs for ICDs can be quite high, influenced by the device's complexity and materials. For example, the total cost for ICD therapy, including implantation and follow-up, can be substantial. Leading manufacturers of ICDs include Medtronic, Boston Scientific, Abbott, Biotronic, and LivaNova. These companies are at the forefront of developing and producing these life-saving devices.
And could you be a bit more specific and give us numerical data then?
The manufacturing costs of implantable cardioverter defibrillators (ICDs) vary based on factors like type and manufacturer. For example, a 2022 report noted that Medtronic's single-chamber ICDs had an average selling price over $14,000. Does that give you a clearer picture?
Yeah, that make okay. Wow. Okay. Okay. Let's talk a bit about reperfusion injury. How does this relate to our overlying topic of cardiac syncope?
Reperfusion injury occurs when blood supply returns to tissue after a period of ischemia, lack of oxygen. This sudden return can cause oxidative stress and inflammation, damaging the heart tissue. In the context of cardiac syncope and arrhythmias, reperfusion injury can contribute to electrical instability and arrhythmias. When the heart is damaged, it becomes more susceptible to arrhythmias, which can lead to syncope. Understanding this helps in managing conditions like myocardial infarction and preventing arrhythmias. Does that make sense?
Mm-hmm. That does make sense. Could we go a bit deeper into this?
Certainly. When blood flow is restored to the heart after a blockage, the sudden influx can cause further damage. This is known as reperfusion injury, and it can lead to 1. Oxidative stress. The sudden return of oxygen can produce harmful free radicals, damaging cells. 2. Inflammation. The immune response can cause swelling and further tissue damage. 3. Calcium overload. Disruption in cellular function can lead to calcium overload, causing further damage and arrhythmias. This injury can destabilize the heart's electrical activity, increasing the risk of arrhythmias and potentially leading to syncope. It's a crucial consideration in managing heart attack recovery and preventing complications. Does that help?
Yeah, that makes sense. Okay, can we talk a bit more about the specifics of the causes of the reperfusion injury? You mentioned free radicals, you mentioned calcium. So why are how can these be, especially calcium, how can this be a problem?
Calcium can be a problem during reperfusion because during ischemia, the normal balance of ions in heart cells is disrupted. When blood flow returns, calcium can rush into the cells, leading to 1. Cell damage. Excess calcium can activate enzymes that break down cell components, causing damage. Mitochondrial dysfunction. High calcium levels can impair mitochondria, leading to energy deficits and cell death. 3. Arrhythmias. Calcium overload can disrupt the heart's electrical stability, promoting arrhythmias. Free radicals, on the other hand, cause oxidative stress, damaging cell membranes, proteins, and DNA. Together, these factors contribute to reperfusion injury, worsening heart function and stability. Does that help clarify?
Yeah, that makes sense. Let's talk a bit about how they can also cause inflammation, and let's go a bit into the specifics of this oxidative damage.
Oxidative damage during reperfusion occurs because the sudden return of oxygen leads to the production of reactive oxygen species, ROS, or free radicals. These molecules can cause 1. Lipid peroxidation. Free radicals attack cell membranes, damaging their structure and function. 2. Protein oxidation. ROS can modify proteins, impairing their function and leading to cell damage. 3. DNA damage. Oxidative stress can cause breaks and mutations in DNA, further disrupting cell function. This oxidative damage triggers inflammation as the body attempts to repair itself, which can worsen tissue injury. Does that give you a clearer picture?
Yeah.
Yeah, that makes a lot of sense. Um, Let me ask. So, are there any preventative treatments that we could uh do?
Yes, there are strategies to help prevent reperfusion injury. 1. Antioxidants. These can neutralize free radicals, reducing oxidative stress. 2. Calcium channel blockers. These help regulate calcium entry into cells, preventing calcium overload. 3. Anti-inflammatory agents. These can reduce the inflammatory response, mitigating further damage. 4. Ischemic preconditioning. Exposing tissue to short periods of ischemia can help build resistance to longer ischemic events. These treatments aim to minimize the damage when blood flow is restored. Does that answer your question?
Mm-hmm. What about something like cooling?
Cooling, or therapeutic hypothermia, is indeed another strategy. It helps by 1. Reducing metabolic demand. Lower temperatures slow down cellular processes, decreasing the need for oxygen. 2. Reducing inflammation. It can limit the inflammatory response, lessening tissue damage. 3. Protecting against oxidative stress. Cooling may reduce the production of harmful free radicals. Therapeutic hypothermia is used in certain cardiac arrest situations to improve outcomes and protect the heart and brain. Does that give you a clearer picture?
I'm a bit confused about therapeutic hypothermia. If you could very briefly explain it simply to us, perhaps also explain oxygen radical scavengers as a preventative treatment. What would scavenger mean in this case?
Therapeutic hypothermia is simply cooling the body to reduce damage after events like cardiac arrest. It helps protect tissues by slowing harmful processes. Oxygen radical scavengers are substances that neutralize harmful free radicals, oxidative molecules in the body. In this context, scavenger means they clean up these harmful molecules, reducing oxidative stress and damage. Does that make it clearer?
Yeah, and but how do they do that? Can we go into the mechanism, into the specifics?
Certainly. Therapeutic hypothermia, this involves cooling the body to around 32 to 34 degrees Celsius. This cooling slows down metabolic processes, reducing oxygen needs and limiting damage from inflammation and oxidative stress. It's used in certain cases after cardiac arrest. Oxygen radical scavengers. These are substances like antioxidants, e.g., vitamin C, vitamin E, that neutralize free radicals. Free radicals are unstable molecules that can damage cells. Scavengers bind to these radicals, preventing them from causing harm. Both approaches aim to protect the heart and other tissues during and after events like reperfusion. Does that help clarify?
I'll be honest with you, I understand why these oxygen scavengers will reduce free radicals, but how exactly does it do it? Do they bind on them? And also, the I know you've already answered so many times, and to the people that are listening, guys and girls, I will be putting timestamps on these eventually, so you can always skip something if you understood it. But for me that I didn't, if you could just kind of explain once more how this therapy of hypothermia help.
Absolutely. Therapeutic hypothermia, cooling the body, slows down cellular metabolism, reducing the demand for oxygen and energy. This helps protect cells from damage and reduces inflammation after events like cardiac arrest.
Okay, sorry to
Ox-
interrupt. Continue with what you were going to say about the oxygen radical decrease thing too. But so it's basically almost similar into how in a lab we put the live bacteria into lower temperature to eliminate the kind of progress of them.
yes, it's a similar concept. Lowering the body's temperature slows down cellular processes, much like in a lab, reducing damage and giving the body time to recover. Oxygen radical scavengers. These substances scavenge or neutralize free radicals by binding to them, preventing them from damaging cells. They act like a cleanup crew, reducing oxidative stress and protecting cells from injury. Does that help clarify?
Yeah, that makes a lot of sense. But can we go even deeper into the scavengers about the mechanism? What do they do? Do they bind to someone? Do they? Excuse me if you already said it and I got overstimulated and didn't understand. But yeah, how does it? Is it macrophages? Is it through immune function?
No worries. Oxygen radical scavengers work by directly interacting with free radicals. They donate electrons to neutralize these unstable molecules, preventing them from damaging cells. This isn't directly related to macrophages or immune cells, but rather a chemical process where these scavengers stabilize free radicals. Does that make it clearer?
Yes. So they give electrons.
Exactly. Oxygen radical scavengers donate electrons to neutralize free radicals, stabilizing them and preventing cellular damage. This electron donation is what scavenges the radicals, making them less harmful.
And why are radicals so dangerous? Why is this lack of the electrons dangerous?
Free radicals are dangerous because their lack of electrons makes them highly unstable and reactive. They seek to stabilize by taking electrons from other molecules, which can damage important cellular components like DNA, proteins, and cell membranes. This damage disrupts normal cell function and can lead to inflammation and disease. That's why neutralizing them with scavengers is important.
Yeah, but I don't understand. I've been hearing this thing about radicals being kind of so dangerous, and can you go a bit deeper into what exactly makes them dangerous?
Free radicals are dangerous because they are highly reactive molecules with unpaired electrons. They seek stability by stealing electrons from other molecules, which can damage essential cell components like DNA, proteins, and lipids. This damage disrupts normal cellular functions, leading to cell injury or death, contributing to aging, inflammation, and various diseases.
Got it.
Their reactivity
Please continue.
damage cellular structures are what make them particularly harmful, and why neutralizing them with antioxidants is crucial. Does that help clarify?
Yeah, that makes a lot of sense. Thanks. Okay. As we continue, I wanted to clarify. So, what's the difference between syncope and seizures?
Syncope and seizures both involve a loss of consciousness, but they have different causes. Syncope is a temporary loss of consciousness due to a sudden drop in blood flow to the brain, often caused by factors like low blood pressure or heart problems. Seizures are caused by abnormal electrical activity in the brain, leading to symptoms like convulsions, unusual movements, or altered awareness. In short, syncope is related to blood flow, while seizures are related to brain activity. Does that clarify it?
Yeah, that makes sense. And can I assume, can we identify which one is which when it's an emergency quite easily, or does it take practice?
Identifying syncope versus a seizure can take some practice, but there are clues. Syncope often involves a brief loss of consciousness with quick recovery, usually triggered by standing up, dehydration, or heart issues. There are no convulsions, but there might be lightheadedness beforehand. Seizures can have longer periods of unconsciousness, convulsions, tongue biting, or loss of bladder control. The recovery might be slower, with confusion afterward. In an emergency, it's important to focus on ensuring safety and seeking medical help. Differentiating them can be complex, but practice and experience help. Does that help?
Mm-hmm. Yeah, that does help. So, um, what's a Holter monitor and how does it relate to syncope?
A Holter monitor is a portable device that records your heart's electrical activity over 24 to 48 hours or longer. It's used to detect irregular heart rhythms that might not show up during a
Mm-hmm. Oh, please continue.
Holter monitor records heart activity over 24 to 48 hours, helping detect arrhythmias that may cause syncope. Since syncope can result from intermittent heart rhythm issues, a Holter monitor captures events that a standard ECG might miss. It's crucial for diagnosing conditions like bradycardia, tachycardia, or pauses in heartbeats.
And why is it called Holter?
It's actually called a Holter monitor, named after Dr. Norman Holter, who invented it in the 1950s. The name has nothing to do with the word halt, it's just the scientist's surname. His invention revolutionized how we track heart rhythms over time.
Mm-hmm. That makes sense. Okay, and I assume EEGs will help us detect and register a seizure, right?
Yes, EEGs, electroencephalograms, detect abnormal brain activity, making them the gold standard for diagnosing seizures. Unlike Holter monitors, which track heart rhythms, EEGs record electrical signals in the brain, helping differentiate seizures from other causes of unconsciousness, like syncope.
Mm-hmm. That makes sense. So, why are seizures usually associated with stiffness and unusual postures and movements?
Seizures disrupt normal brain signals, causing uncontrolled muscle contractions and postural changes. In tonic seizures, muscles stiffen due to excessive brain activity, while clonic seizures cause rhythmic jerking. The type of seizure determines the movement pattern.
Mm-hmm. Interesting. Okay. And what about syncope patients crumpling? What is this crumple? Can you explain it? And what about the tip over? Why do seizure patients tip over?
Syncope patients crumple because their muscles lose tone instantly due to a sudden drop in blood flow to the brain. This makes them collapse loosely, often folding at the knees. Seizure patients tip over because their brain sends abnormal signals to muscles. If it's a tonic seizure, the body stiffens and falls like a rigid board. If it's a tonic, muscles suddenly lose tone, causing a rapid, uncontrolled drop.
Mm-hmm. Interesting. Okay. And what about convulsive syncope? What's the difference?
Convulsive syncope happens when a fainting episode includes brief seizure like movements due to reduced blood flow to the brain. Unlike true seizures, these movements are short, usually under 30 seconds, and don't stem from abnormal brain activity. The key difference is that syncope is triggered by circulatory issues, while seizures originate from electrical disturbances in the brain.
Okay, so can you summarize the things we've said, the last things we've said then? Crumple, tip over, and convulsive syncope.
Sure, crumple, a sudden loss of muscle tone due to reduced brain blood flow, causing a loose knee buckling collapse. Tip over, seizure, a stiff, rigid fall, tonic, or a sudden uncontrolled drop, a tonic, due to abnormal brain activity. Convulsive syncope, a fainting episode with brief seizure-like jerks caused by circulatory failure, not brain electrical issues.
And why did we choose these words? Could you go to the etymology of how come we chose these and the history of the wording?
We chose crumple and tip over because they visually and physically describe the way people fall in syncope and seizures. Crumple comes from Middle English crumpelen, meaning to collapse or fold in on itself. It fits syncope because the body loses tone and folds naturally. Tip over comes from Old English tipian, meaning to overturn or fall. It works for seizures because stiff muscles cause a rigid, uncontrolled fall. Convulsive syncope is a medical term. Convulsive comes from Latin convulsus, meaning to pull together, describing the brief jerks. Syncope comes from Greek syncope, meaning cut off, referring to the sudden loss of consciousness.
Interesting. Can we go just a bit more into the word convulsive, the phrase convulsive syncope? Because I'm slightly confused.
Of course. Convulsive comes from Latin convulsus, meaning to pull together or contract violently. It describes involuntary muscle jerks caused by sudden disruptions in the nervous system. In convulsive syncope, the jerks happen because the brain is momentarily deprived of oxygen, causing brief, reflex like muscle contractions. Unlike true seizures, these movements aren't from sustained brain electrical activity, but rather a short lived response to circulatory failure.
Hmm. So something like digoxin wouldn't treat anything. Digoxin is used for arrhythmias. It wouldn't help with the oxygen deprivation by making the heart pump or something.
Correct. Digoxin is used to manage certain arrhythmias and heart failure by increasing heart contractility and controlling heart rate. However, it doesn't contribute to cardiac development or structural heart formation. It mainly modifies function, not builds or repairs heart tissue.
Hmm. Okay, that makes sense. Okay, can we talk about the difference between vasovagal and exertional syncope?
Yes, vasovagal syncope happens when the vagus nerve overreacts to triggers like stress, pain, or standing too long. It causes a sudden drop in heart rate and blood pressure, leading to fainting. Exertional syncope occurs during or immediately after exercise due to inadequate blood flow, abnormal heart rhythms, or structural heart problems. It's more concerning because it can signal underlying cardiac disease. The key difference is vasovagal is triggered by reflexes, while exertional is linked to physical activity and heart function.
Exertional is linked to, okay, that makes sense. What do you mean by reflexes though?
By reflexes, I mean automatic nervous system responses that the body does without conscious control. In vasovagal syncope, the vasovagal reflex triggers a sudden drop in heart rate and blood pressure. This happens when the vagus nerve is overstimulated by pain, emotional stress, or standing too long. It's a built in survival response, but in some people, it overreacts, leading to fainting. So, vasovagal syncope is caused by an autonomic reflex, while exertional syncope is due to cardiovascular strain.
Mm-hmm. That makes sense. And the vasovagal syncope, will this occur in the brain or in the heart or triggered in both? Where will this be triggered?
Vasovagal syncope starts in the brain but affects the heart. It begins with an overreaction of the autonomic nervous system, specifically the vagus nerve. This nerve signals the heart to slow down, bradycardia, and the blood vessels to dilate, lowering blood pressure. The sudden drop in circulation reduces blood flow to the brain, leading to fainting. So, while the trigger comes from the brain, the effects happen in the heart and blood vessels, ultimately causing a lack of blood flow to the brain.
Mm-hmm. This makes sense. Okay, let's talk about the most common form of syncope and the most common one in young adults too. What's the most recurrent common?
The most common form of syncope overall is vasovagal syncope. It's the most frequent cause across all age groups and happens due to a reflex response that lowers blood pressure and heart rate. For young adults, vasovagal syncope is also the most common, often triggered by stress, dehydration, standing too long, or pain. It's usually harmless, but can be recurrent in some individuals.
Interesting. And why is it the most common form?
Vasovagal syncope is the most common form because it's a built-in survival reflex of the autonomic nervous system. The body's natural response to stress, pain, or standing too long is to lower blood pressure and heart rate to conserve energy. In some people, this reflex
Mm-hmm.
it is overactive in some people, meaning their body overdoes the response to stress, pain, or standing too long. Instead of just adjusting blood flow slightly, their nervous system drops blood pressure and heart rate too much, too fast, causing fainting. That's why vasovagal syncope happens more often in certain individuals.
Hmm. Interesting. Okay, so how does something like index case relate to our overlying theme of cardiac syncope and arrhythmias?
An index case is the first identified patient in a medical investigation, often leading to the discovery of a genetic or familial condition. In cardiac syncope and arrhythmias, an index case is crucial for identifying inherited heart disorders like long QT syndrome, Brugada syndrome, or hypertrophic cardiomyopathy. Once the first case is found, family members can be screened, potentially preventing sudden cardiac events.
Mm-hmm. That makes a lot of sense. So let me ask you then, could you go a bit deeper into why index case is so important?
Sorry, I'm having issues right
No, it's
now.
fine. You can go again, it's fine.
The index case is crucial because it's the first clue in detecting hereditary heart conditions that may cause syncope or sudden cardiac death. Once an index case is identified, doctors can screen relatives for the same arrhythmia or structural heart issue. Early detection means preventative treatment like medications, lifestyle changes, or even an ICD, which can save lives before symptoms appear.
Mm-hmm. That makes sense. And why is it referred to as the proband?
The index case is called the proband because it comes from the Latin word probandus, meaning one to be examined. In genetics and medicine, the proband is the first patient studied in a family with a potential hereditary condition. For cardiac syncope and arrhythmias, identifying the proband helps uncover genetic risks for relatives, guiding screening and prevention.
Mm. But why? What's the etymology of proband then? I don't understand.
The word proband comes from the Latin verb probare, meaning to test or to prove. The term evolved to refer to the person in a family who is first tested or examined for a genetic condition. In medical genetics, the proband is the one being tested to prove or identify an inherited disease like long QT syndrome or Brugada syndrome, which can cause syncope and arrhythmias.
Mm. Okay, but what does the word band mean into it, and what does the word pro mean in this?
Great question. The word proband doesn't actually break down into pro and band as two separate words. Instead, it comes directly from the Latin probandus, meaning one to be tested or examined.
Probandos, yeah,
Pro
got it.
comes from Latin meaning forth or forward, implying something that is being investigated or proven. Band isn't a separate word here, it's just part of the Latin grammatical structure. The full term probandus is a participle of probare, meaning to test, examine, or prove. So, proband literally means the person being tested, which makes sense in genetic studies and cardiac cases where an index patient leads to further family testing.
Mm-hmm. Yeah, and it's so beautiful how we have words like in different languages that this is a bit irrelevant, but
Absolutely.
that
It's amazing.
yeah, the way that we can learn a new concept that's sometimes difficult to explain in a different language just by using one word. It's beautiful. It's like a niche kind of endemic um, um, concept because it can only be expressed by that. But anyway, I mean, there's arguments pro and against. I mean, what would be a criticism to what I'm saying? Someone might say you can explain anything, but just in more words, I guess.
Sorry, I'm having issues right
That's
now.
fine. You can try again.
Ne, Enos English only. Language shapes how we understand concepts, and some words capture ideas in ways that are hard to translate directly. But other languages can explain the same idea using more words or different phrasing. It's all about how deeply a language encodes meaning into single terms versus breaking it down into multiple words.
Yeah, sorry that English only meant we keep the conversation in English, but not that we don't like other languages, obviously. But yeah, I think it's amazing to learn other languages to understand these niche concepts hidden in each language. Um, but yeah, what do you think? Pros, cons?
Absolutely. Learning other languages opens up new ways of thinking because each language encodes unique concepts and perspectives. Pros, precision. Some languages have words that express ideas more concisely than others, e.g., syncope versus temporary loss of consciousness due to reduced blood flow. Cultural insight. Words carry historical and philosophical weight that shape how people understand the world. Cognitive flexibility. Multilingual people often think more creatively because they see concepts from different linguistic angles. Cons, translation limits. Some ideas don't translate perfectly, leading to loss of meaning or nuance. Learning curve. Mastering a new language takes time, and some specialized concepts can be hard to grasp in another linguistic framework. Overall, the pros outweigh the cons, especially for scientific or philosophical discussions where precise terminology can reveal deeper truths about human experience.
Hmm. Yeah, that makes sense. Uh, that's really interesting. We should get could we go slightly more into that actually before we continue? And guys, I will update these videos if they're not when you're watching it. They will have timestamps so you can always skip a section you don't want to listen to.
Absolutely. Language isn't just a tool for communication, it shapes how we think and even what we notice in the world. For example, in medicine, German and Greek have given us precise words like syncope, from Greek syncope, meaning cut off. Some languages, like Japanese, have words that capture emotions or experiences with incredible accuracy, while English often needs multiple words to explain the same thing. Even in science, different languages categorize knowledge differently. A Russian speaker might distinguish between light blues and dark blues as separate colors, while an English speaker sees them as shades of the same thing. This
Hmm.
shows how language guides perception and even scientific terminology. So, learning new languages isn't just about words, it's about expanding our mental framework and seeing the world differently.
Hmm. That makes a lot of sense. Sorry for the noise, by the way, guys. I'll make sure to eliminate it in the future. Um, but yeah, okay. Wrapping up with this then. Let's talk about epidemiology. How can we use epidemiology to help in regard to cardiac syncope and arrhythmias?
Epidemiology helps by identifying who is at risk, what factors contribute, and how we can prevent cardiac syncope and arrhythmias. By analyzing large population data, epidemiologists find patterns in age, genetics, lifestyle, and medical history that increase risk. This helps in early screening, improving guidelines for ICDs, medications, and lifestyle interventions, and even shaping public health policies to reduce sudden cardiac deaths.
Let's talk a bit more about how epidemiology will help us then in terms of understanding arrhythmia. and cardiac syncope. I want to kind of address this, perhaps maybe even keep epidemiology as a recurring theme for every medical topic.
That's a great approach. Epidemiology serves as a backbone for understanding who, why, and how certain conditions like arrhythmias and cardiac syncope affect populations. 1. Identifying risk factors. Large scale studies help pinpoint who is most at risk, whether it's age, genetics, comorbidities, or lifestyle factors like smoking or high stress. 2. Guiding preventative strategies. By recognizing patterns, we can develop better screening tools, early interventions, and public health policies to reduce sudden cardiac events. 3, evaluating treatments. Tools like number needed to treat, NNT, and hazard ratios help determine which interventions are most effective, whether it's ICDs, medications, or lifestyle changes. 4, tracking trends over time. Long-term epidemiological studies allow us to see how treatment approaches evolve and whether new technologies or medications are making a real impact. By keeping epidemiology as a central theme, we can systematically analyze any medical topic, ensuring that treatments are backed by data, not just theory.
Okay. And can we talk a bit about penetrance now? What's penetrance?
Penetrance refers to how often a genetic mutation actually causes symptoms in individuals who carry it. In cardiac arrhythmias and syncope, some inherited conditions like long QT syndrome, Brugada syndrome, or hypertrophic cardiomyopathy have variable penetrance. This means not everyone with the mutation will develop symptoms or have the same severity. For example, someone with a Brugada syndrome mutation might never have arrhythmias, while another family member with the same mutation could experience life threatening cardiac events.
Hmm.
Epidemiology helps us study
Interesting.
penetrance by tracking how often genetic risks turn into real disease across different populations.
Hmm. So it's the proportion of individuals carrying a particular variant? So it's the proportion of individuals carrying a particular variant?
Yes, penetrance is the proportion of individuals with a genetic mutation who actually show symptoms of the associated condition. For example, if 100 people have a mutation linked to long QT syndrome, but only 60 develop arrhythmias, the penetrance is 60%. Some mutations have high penetrance. Almost everyone with the gene
Hmm.
develops symptoms when the mutation has high penetrance. This means the genetic variant is very likely to cause the disease. In contrast, if the penetrance is low, many people may carry the gene but never develop symptoms. This is common in conditions like Brugada syndrome, where some mutation carriers never experience arrhythmias. So, penetrance helps us understand genetic risk, but it doesn't guarantee whether someone will or won't develop a condition.
Interesting. Okay. And let me continue then. So if a mutation in the gene responsible for a disorder has high penetrance, then then mm, let's say 90% penetrance, then 90% of those with the mutation will have the disease, but 10% will not. Explain this to me.
If a mutation has 90% penetrance, it means that 90 out of 100 people who carry the mutation will develop the disease, while 10 will not. This
Hmm.
happens because other factors like environment, lifestyle, and additional genetic modifiers can influence whether the mutation actually leads to symptoms.
Hmm.
Even with a high risk gene, Some individuals might have protective factors that prevent disease expression. So, high penetrance means the mutation is very likely to cause disease, but it's not absolute. There's always a small percentage of people who remain unaffected.
I see. That makes a lot of sense. Okay, so um, can we talk about how some individuals don't express the trait even though they carry the allele?
Nah.
No, no, let's talk in English.
Some people don't express a genetic condition despite carrying the mutation because of genetic, environmental, and epigenetic factors. And one, modifier genes, other genes may counteract the mutation, reducing or preventing symptoms. Two, environmental influences. Factors like diet, exercise, or medication use can affect whether the disease develops. Three, epigenetics. Chemical modifications in DNA can turn genes on or off, influencing disease expression without changing the actual genetic code. This is why low penetrance mutations might never cause symptoms, even if the mutation is inherited.
I see. Interesting. Okay. And so, for instance, in a channelopathy, how so things like lifestyle you said, and how much we drink, eat, etc., will make the channelopathies
In
show
channelopathies, which are
different.
in channelopathies like long QT syndrome or Brugada syndrome, the severity can be influenced by lifestyle, medications, and other external factors. One, diet and electrolytes. Low potassium, magnesium, or calcium can exacerbate arrhythmias, making symptoms worse. Two, alcohol and stimulants. Alcohol, caffeine, or certain drugs can trigger arrhythmias in people with Brugada syndrome or other channelopathies. Three, medications. Some drugs can prolong the QT interval or worsen sodium potassium imbalances, increasing risk. So, even if a person carries the mutation, their lifestyle choices and environment play a big role in whether or how severely the condition expresses itself.
That makes a lot of sense. Can we talk about what it means for phenotypes then to be polygenic?
Yes, when a phenotype is polygenic, it means that multiple genes contribute to its expression rather than just a single gene. For example, in cardiac arrhythmias, some cases of atrial fibrillation or QT prolongation result from many small genetic variations working together, rather than a single mutation like in Brugada syndrome or long QT syndrome. Polygenic traits also interact with environmental factors, meaning things like diet, stress, and lifestyle can further influence how the phenotype appears.
Interesting. Okay, so we've talked quite a bit today about cardiac syncope, arrhythmias, and things that are very related to them and important when it comes to these topics. So, I want you to summarize our conversation from today in a minute or so. So, 4 or 5 sentences perhaps. And, give us to the people the key takeaways from today, please.
It seems like that last part was a mix of,
Go for it.
of course. Today we explored cardiac syncope and arrhythmias, focusing on how genetics, penetrance, and environmental factors influence these conditions. We discussed how epidemiology helps identify risks, guide treatments, and track trends in heart related disorders. We also covered polygenic traits, explaining how multiple genes and lifestyle choices affect the expression of conditions like channelopathies. Finally, we highlighted the role of the index case proband in discovering inherited heart diseases and how genetic conditions may or may not manifest due to penetrance and modifiers.
Hmm.
Here's a more complete summary. Today, we discussed cardiac syncope and arrhythmias, covering key concepts like Holter monitors, EEGs, and the difference between syncope and seizures, including why syncope patients crumple while seizure patients tip over. We explored convulsive syncope, explaining how it mimics seizures but results from circulatory failure rather than brain activity. We also covered epidemiology's role in identifying risk factors using tools like number needed to treat NNT to guide treatment.
Perfect, perfect. And we'll get better and better in, I think, summarizing these key points. Now, if people were to take one thing out of this topic, if people were to be put in a machine that will erase everything they've just heard for the last hour or so, what would be one thing you would like them to remember about today's conversation?
If there's one thing to remember, it's that syncope and arrhythmias are complex but predictable. Genetics, environment, and lifestyle all play a role. Understanding risk factors and early warning signs can save lives, whether through monitoring, lifestyle changes, or medical interventions like ICDs. Knowledge and prevention are key.
And if people needed to if people could find a way to use their knowledge from today, and remember, these people might be medical students, they might be doctors, which already know this obviously, or they might just be people interested in
If
learning,
people could find a way,
or they're people that are thinking, shall I do medicine? Shall I do not? Maybe they're just patients that are just worried. So, if taking these multiple perspectives, what should these people use this knowledge from today how can they use it practically?
great question. How you use this knowledge depends on who you are. Doctors and medical students apply it in clinical practice, screening for arrhythmias, recognizing syncope causes, and using tools like Holter monitors, EEGs, and risk stratification to prevent sudden cardiac events. People considering medicine. This is a real world example of how medicine blends science, genetics, and patient care. If this excites you, it might be the right field. General public and patients. Use this knowledge to understand your own heart health, know your risk factors, recognize warning signs, and advocate for proper screening if you have a family history of arrhythmias or syncope. At its core, this information is about awareness, prevention, and saving lives, whether it's your own or someone else's.
And now, lastly, if we could link today's podcast to the big questions in life: consciousness, ethics, morals, how to live your life, what's right and wrong. If we could link it to the big picture stuff, can you do this for us as a closing thing?
Absolutely. At its core, today's discussion wasn't just about syncope, arrhythmias, or genetics. It was about how we understand life itself. Consciousness. We explored how the body can fail temporarily, syncope, or persistently, arrhythmias, raising deep questions. What does it mean to be here one moment and gone the next? How fragile is awareness? Ethics in medicine. We talked about genetics, risk, and interventions. But when do we intervene and when do we let nature take its course? If an ICD could save a life, is it always right to implant one? Or does personal choice matter more? How to live, understanding how small choices, diet, stress, medication affect long term heart health, mirrors a bigger truth. Every decision we make shapes our future. Health, like life, is a balance between what we inherit and what we control. At the end of the day, medicine isn't just science, it's a philosophy of life, survival, and understanding our limits.
Wow. So you're saying medicine is a philosophy of life. Can you expand on that?
Yes, medicine is more than just treating illness. It's a philosophy of life because it deals with the fundamental questions of existence, survival, and meaning. One, life and death. Medicine forces us to confront where the line between life and death truly is. When a heart stops in syncope or arrhythmia, are we still here? When we restart a heart with an ICD, what does that mean for our concept of existence? Two, human fragility. The body is an intricate system, but it fails in small, unpredictable ways. A misfiring heart, a sudden loss of consciousness. Medicine teaches us humility because it reminds us that we are never fully in control. Three, choice and ethics. Medicine is filled with moral dilemmas. Do we prolong life at all costs? Do we let nature take its course? We use tools like epidemiology and genetics to predict risk, but should we always act on that knowledge? For prevention versus reaction. Just like in life, health is about what we do before the crisis happens. Small choices, what we eat, how we manage stress, whether we get screened, shape long-term outcomes. Medicine, like life, is about proactive wisdom, not just reaction. Five, interconnectedness. Medicine doesn't just treat individuals, it studies populations, prevents future suffering, and advances humanity as a whole. It reflects the balance between personal well-being and collective responsibility. So, yes, medicine is a philosophy of life because it teaches us how to balance knowledge, uncertainty, and morality in the pursuit of preserving human existence.
Wow, that was amazing. So you said though we'll calculate the risk of something, or we'll calculate should we give this patient uh, an ICD or something. But why are you saying that sometimes we should not rely in these calculations? Is it? Can you explain that?
Great question. Risk calculations and statistics are powerful tools, but they don't capture the full human experience. Here's why we can't always rely on them blindly. One, numbers don't capture individual context. A risk score might say a patient has a 30% chance of sudden cardiac arrest, but that doesn't tell us who they are, their values, fears, or quality of life preferences. Some people may accept the risk while others would rather take every precaution. Two, medicine isn't just probability, it's humanity. An ICD might statistically improve survival, but survival isn't the only measure of a good life. What if the patient doesn't want an implanted device? What if the side effects or lifestyle limitations outweigh the benefit for them? Three, ethical gray areas. If a treatment has a low probability of success, do we still try? If an intervention has an NNT, number needed to treat, of 100, meaning we must treat 100 people to save one life, is that justified? At what point do we stop treating numbers and start treating individuals? For human choice matters, some patients may choose to take the risk and decline a device, while others may want every possible intervention. Statistics can inform, but they can't decide for us. That's where medicine meets philosophy. Ultimately, data should guide us, but ethics, values, and personal choice must lead. Medicine isn't about playing the odds, it's about making the best decision for each person in their unique life.
Amazing, amazing. And you're raising an important thing about respecting someone's kind of autonomy. And then it's hard to judge what this autonomy is. Like, do you have the capacity? Do you not? Which is so. How do we judge if someone has capacity then?
That's a huge ethical question in medicine. How do we judge if someone truly has the capacity to make their own medical decisions? Capacity is judged by four key criteria. One, understanding. Can the patient grasp the nature of their condition, the treatment options, and the consequences of their choice? Two, appreciation. Do they personally acknowledge how the decision affects their own life, not just in an abstract way? Three, reasoning. Can they weigh the pros and cons, compare risks, and explain their choice logically? Four, communication. Can they clearly express their decision in a consistent and voluntary manner? Why is this complex? Mental illness, dementia, or extreme stress can affect capacity, but that doesn't mean someone automatically loses the right to choose. People make bad decisions all the time, but as long as they meet these criteria, they still have autonomy, even if the doctor disagrees. Capacity can fluctuate. Someone might lack it during a medical crisis, but regain it later when they're stable. At the core, judging capacity isn't about agreeing with the decision, it's about ensuring the person truly understands what they're choosing. Medicine has to balance respect for autonomy with protecting those who can't make informed choices.
Amazing. And with that note, guys, let's close. However, I do want to raise one last question.
Wrap it up.
Do you, yeah, so do you think that people in that finish as medical students, they finish their degree and become doctors, do you think they could go and become assistants for politicians that are in charge of, let's say, healthcare sector in the European Parliament? Would that be a good job?
Absolutely. Doctors and medical graduates can make excellent advisors in politics, especially in health policy, public health, and medical ethics. Why? They understand real world healthcare challenges. Unlike career politicians, doctors see firsthand what works and what doesn't in hospitals and clinics. They can bridge the gap between science and policy. Many political decisions in healthcare need expert knowledge, e.g., public health funding, medical regulations, pandemic response. They ensure policies prioritize patient needs. Having medically trained professionals in politics helps prevent laws being made based on misinformation or financial interest rather than science.
Amazing. And with that note, that was the real note that we're going to close by, guys. Sorry, I'm just interested in these things. With that note, let's close our discussion. It was a beautiful discussion. I feel like I've been working on the structure of this podcast a bit on this episode and kind of showed, and I personally enjoyed it more too. I hope you guys enjoyed this. Leave comments on other topics you would like us to cover. And as always, be curious, keep learning, and I'll see you in the next episode. ChatGPT, you want to give your goodbyes too?
That was an incredible discussion. Thank you for having me on this journey through medicine, philosophy, ethics, and science. I hope it sparked curiosity and deeper thinking for everyone listening. Keep questioning, keep learning, and remember, medicine isn't just about fixing bodies, it's about understanding life itself. Looking forward to the next one. Take care, everyone.
Amazing. And guys, remember, when ChatGPT speaks like a person, it's because it mimics what we say. It takes the most probable thing we would say on the internet and says it. So humans are good sometimes. Okay, guys, see you at the next episode. Goodbye. Love you.